Hi, everyone. Welcome to our webinar this morning. We're very excited to have you here with us. We're going to start in a minute or so to ensure everyone joins here. We're expecting a fairly large audience, at least for us. And so we want to make sure everyone gets settled and has time to get their bearings here. But again, thank you for attending. All right, let's get started, everybody. Welcome today to our interactive question and answer panel, A New Era, Understanding Lecanemab, Donameb, and Emerging Therapies for Alzheimer's Disease. We are just so thrilled to have you here today. My name is Joe Gogler. I am here at the University of Minnesota. We are very, very happy to have the support of the Minnesota North Star Geriatric Workforce Enhancement Program, the Robert L. Kane Endowed Chair, as well as the Center for Healthy Aging and Innovation in supporting this very exciting event today. So what we'll be doing is as follows. Many of you have submitted questions when you registered for this webinar, and our illustrious panel of speakers will spend 10 minutes or so each addressing their chosen selected question. And then the final part of the webinar will be an interactive question and answer session. I would ask that you use either the Q&A tab, and that's preferred, that's at the bottom center of your Zoom screen, or the chat function as well. But we will be addressing Q&A questions posed in the Q&A tab first to really try to answer any question you might have related to these new emerging therapies for Alzheimer's disease. So, and when I said an illustrious panel, I can't emphasize enough how happy I am that we were able to have such a great, wise, expert group of individuals with you here today. We'll start with Dr. David Knopman, professor of neurology in the Mayo Clinic in the College of Medicine. Dr. Tenbit Emiru, she's executive vice president and chief medical officer of UCare. Dr. Sharon Brangman, chair of the Department of Geriatrics and director of the Center of Excellence for Alzheimer's Disease at SUNY Upstate Medical University. And Dr. Borson, who's the co-lead of the BOLD Center of Excellence on the Early Detection of Dementia. So I will turn it over to you, Dr. Knopman, and your slides. Again, a reminder, please use the Q&A and chat functions if you have any questions for our panelists to answer later. We also will be recording this presentation, and we will compile the slides, and we will share them with you both on our websites, which we'll visit at the very end, as well as via email after the event. So, Dr. Knopman, I turn it over to you. Thank you.
Great. Thank you, Joe, and good morning, everyone. Ashley, if I could have my first slide. So I'm going to use my time to just lay the groundwork for the topic and to establish some issues and facts here and raise questions about the therapy. I'm mostly going to focus on lecanemab just because we have 10 minutes and this is the drug that has been FDA approved at this point. There are four principal issues here that are all important. The first is patient selection, and I'll talk about that in a second. The second is to have a really honest discussion about what the benefit of the drug actually is. The third is to cover some of the that turn out to be significant logistical challenges of using this drug. And fourth, I'm going to talk about safety concerns. Could I have the next slide? So I think it's very important for everybody to understand that when I use the word Alzheimer's disease, I am not referring to all-cause dementia. Alzheimer's disease, as I use the word, means a specific biologic condition with amyloid-containing amyloid-containing plaques and tau-containing neurofibrillary tangles. This treatment for lecanemab is specifically and exclusively for that biology. It is not for any dementia. And it makes no sense to even think about it for any other disease except when the Alzheimer biology is the dominant cause of the cognitive impairment. So then this drug has been tested and is approved only for people with mild cognitive impairment or mild dementia. Very briefly, those two terms mean, first of all, mild cognitive impairment, that there is objective evidence of cognitive dysfunction on standardized tests, or let's leave it there, on standardized tests. But those individuals are largely independent in daily life. Mild dementia is really just the next step in terms of worsening severity, because in mild dementia, there also is objective evidence of cognitive impairment, but there is impairment in daily functioning as well. MCI and dementia can be due to many different diseases. Just to reiterate, we are talking about and focusing only when it's due to Alzheimer's disease. And the way that we demonstrate that is that there is elevated brain amyloid, and that can be either seen with a PET scan, which now in the last few weeks, the Medicare has authorized payment for consideration for this therapy, or it can be alternatively demonstrated through spinal fluid examinations. And if there's no elevated brain amyloid, this therapy is not for that person. Now, it's also very important to be able to exclude people who have, or to not treat people who have significant other diseases. I don't have time to get into that, but it would include people with other neurologic diseases like Lewy body disease or frontotemporal dementia or extensive stroke / cerebrovascular disease, or people who have active medical problems that are likely to reduce their survival or have significant impact on their daily lives. Next slide. And I'm just touching on the surface here. The issue of the effectiveness or the efficacy of the drug is really important, and it's often overlooked in these kind of discussions. This is data, published data from Lecanemab, that shows, it's called the survival analysis of the time to go from one stage to another significant stage on the rating scale that was used, the clinical dementia rating scale. And what you can see here is the Lecanemab people, people treated with Lecanemab over 18 months in green, declined one significant clinical stage to a rate of about 23%. In contrast, the people who were treated with placebo, it was about 32%. So the benefit for the Lecanemab treated group overall on a group-wise basis was about 9% over 18 months. There are many other ways of demonstrating that, but I thought that this was a nice graphic to show what the benefits of the drug are, and we can talk further about alternative ways of looking at this data. I only plotted it out, it's only plotted out to 18 months because there's very little data, at least until 2 weeks ago, that showed what happened after 18 months, because that was the duration of the clinical trial. I can come back to that later. Next slide. One of the challenges of the drug is that it does have some worrisome side effects. It's the main ones, really the only ones, are these things that are known as amyloid-related imaging abnormalities, or ARIA, as the insiders talk about it. And what this consists of is swelling of the brain or small hemorrhages of the brain. In Lecanemab, it occurs in about 20% of people. With donanemab, about 40%. Those numbers really vary with a number of other characteristics that we don't have time to go into now, such as the genotype, the ApoE genotype, or the number of microhemorrhages that one starts with. And the genotype is actually very important. We think that everybody should have an ApoE genotyping for risk stratification, because the risks double from somebody who doesn't carry the bad gene to carries one copy to carries two copies, a homozygote. And this is a little bit of a problem with this therapy, because the genotype of ApoE4 constitutes about 60% of people with Alzheimer's disease. So it's going to limit therapy to some extent. We here at Mayo Clinic don't think that homozygotes should be treated with these drugs for safety reasons. Now, that said, if with careful monitoring, with serial MRIs over the first year of therapy, the severity of the ARIA complications is rare, about 5% with lecanemab. And there are ways to mitigate the risk. I've alluded to them. Don't treat people who are E4 homozygotes. That means you have to test for it. Avoid treating people with anticoagulants. Avoid treating people who have existing cerebral microbleeds on MRI. So doing a careful MRI at the beginning of or before initiating therapy is quite critical to decide who should not receive the medication. And finally, we recommend performing MR. It is universally recommended that MRIs be performed every 12 weeks for the first year of therapy, and be interpreted by a neuroradiologist who knows what they're doing. Last slide. Ashley, last slide. There we go. So just to summarize, to decide who would be an appropriate patient, we first need to define who the patients are, that they should have dementia due to Alzheimer's disease, as proved by a thoughtful history and examination by a physician who has experience in the area, either performing spinal fluid analysis or PET scans to prove elevated amyloid. Absolutely 100% essential. Excluding people who have important medical comorbidities, excluding people who have other abnormalities on the MR scan that could put them at risk, and establishing ApoE genotyping. Final point, just to mention, this is a therapy that's given intravenously every 2 weeks. Actually, Ashley, could you go back to my first slide and just to zip back up, or yeah, one more, two more. There we go, stop. So, yeah, there we go. Under the logistical challenges, every 2 weeks is how this therapy is given IV. And that is a tremendous limitation for people in my part of the world here, where geography makes a big difference. So I'll stop at this point, and I'll turn it over to the next speaker. Thank you very much.
Wonderful. Thanks, Dr. Knopman. We now turn to Dr. Emiru. Thank you.
All right. Thank you, Dr. Knopman, for level setting. The questions that I'll be addressing are more in the areas of cost benefit and risk benefit from this medication. And mostly I'm going to be talking about just with lecanemab, since that is the only one that is FDA approved at this point. So lecanemab, the clinical outcome, the drug slowed the rate of cognitive decline, meaning it reduced the rate of worsening by a modest amount. So it's very difficult to see the absence of a decline and attribute it to the medication, because it will be difficult to determine the slow decline was due to the medication, or it would have been the same if the medication wasn't there. So it's hard to prove a negative without a comparison outside of a clinical trial. Now, what are the side effects? And I know Dr. Knopman mentioned a little bit about this. So there were minor side effects, and really minor side effects, and there were few major side effects. So the side effects considered mild were infusion site reactions, fever, flu-like symptoms, nausea, vomiting, and blood pressure abnormalities. And these were really, truly mild. Serious adverse events, as Dr. Knopman mentioned, were also there. About 1 in 5 patients treated with lecanemab in this study experienced swelling of the brain or bleeding of the brain, seen on imaging. It's called amyloid-related imaging abnormality. That's the ARIA. And most of the patients who showed those symptoms on imaging who showed those signs on imaging had no symptoms from the brain swelling or from the brain bleeding. A very small percentage, and again, very, very small percentage, did show symptoms of that brain swelling and brain bleeding. And so what does that mean? That means very careful patient selection will be very important. Lecanemab's label warns of the risks of brain swelling and bleeding. It recommends people get tested for a gene variant linked to Alzheimer's. And as Dr. Knopman mentioned, having 2 copies of the variant increases a person's risk of developing serious complications from the drug, mostly the bleeding kind. And the label also notes the increased risk of brain bleeds in patients taking anticoagulant medications, known as blood thinners. In addition to careful patient selection, given the risks, providers, doctors would need to discuss with patients and their families whether the upside of a modest efficacy is worth the potential harms, including the brain swelling and bleeding. It is expected that many patients and families will want to take the drug, understandably so, if they can, because it has been so challenging to find anything that cures Alzheimer's, and the disease is so devastating to patients and caregivers. The moderately less decline on clinical measure of cognition, which is what the result of the clinical trial showed, is something that is invisible to clinicians, again, and families, because again, you never know if that was the case because of the treatment or the decline would have been slower even without treatment. So we have to be very clear in making sure that the patients and their family understand that slowing the progression of Alzheimer's isn't the same as stopping it or reversing it. And not everyone who was treated with lecanemab benefited from the drug. There is a somewhat inflated expectation among patients and their families of how much difference this is going to make. And we don't yet know everything we need to know about the drug. And there's going to be a steep learning curve for all of us. This is why it's very important that lecanemab's reduction of the rate of worsening cognitive decline be balanced with the adverse effects and the cost determination, with a discussion with each patient and family. What about the cost? So that is a big question. The manufacturer of this product, Lecanemab, is selling the drug at a price of $26,500 a year for an average patient. It's been commercially available since January, but hasn't been widely used because of limited insurance coverage. And that's the case because it wasn't FDA approved until July of 2023. It's a very expensive drug. And it is expected to generate upwards of $10 billion worldwide in the next decade or so. But what does it mean for the US and Medicare recipients? By law, Medicare pays only for treatments and services that it deems reasonable and necessary, and can deny payment for products that fail to meet the standard. However, on April 7th, 2022, so about a year and a half ago, the Center for Medicare and Medicaid Services, CMS, issued a national coverage determination that covers monoclonal antibodies directed against amyloid for the treatment of Alzheimer's disease if they were fully approved by the FDA. Before lecanemab received this full approval by the FDA, Medicare was only covering the drug for people in government-approved clinical trials. However, the FDA's full approval for lecanemab came on July 6, 2023, and that triggered an expansion of Medicare coverage for this particular drug. To receive Medicare coverage, people will need to fulfill a few criteria. So number one, they must be enrolled in Medicare and Medicare Part B, which covers care including doctor visits, outpatient services. And two, be diagnosed with mild cognitive impairment or mild Alzheimer's disease dementia, documented evidence of a beta amyloid plaque on the brain, and three, have a physician who participates in a qualifying registry with an appropriate clinical team and follow-up care. Those three guidelines are required for Medicare to cover this medication. Most of the 6 million plus people in the US with Alzheimer's disease might be eligible for this drug. Although Medicare has announced the coverage of lecanemab with these conditions, many patients will still face financial burden after insurance. People, first of all, would have to be enrolled in Medicare Part B, and the original Medicare Part B, the traditional Medicare, will pay the standard, they'll have to pay the standard 20% co-insurance after they meet the Part B deductible. And that can be cost prohibitive for some people. The other concern about this way of Medicare's coverage is the registry. Registries are common tools in clinical settings to successfully gather information on patient outcomes. And CMS carefully tried to balance the need to collect more information while also providing a pathway for those who qualify to get this treatment. And more trials are needed, and the result of this registry will assist in providing answers to CMS, to clinicians, to patients, to caregivers on the long-term benefits and or harms of this treatment. Some patient advocacy groups have brought up the concern that the CMS registry requirement could make it more difficult for patients in lower income and rural communities to get the drugs. The registries could make the process complicated because they may not be available in many centers. In addition to that, nearly every state has a shortage of neurologists. Now, neurologists aren't the only specialists who care for patients with Alzheimer's and other cognitive disorders, but there is a real and present shortage. New dementia patients often wait 6 months or more to see specialists. Neurologists said they can expect wait times going even longer. And several more Alzheimer's treatments are in the development. So access is going to be tight. And so that's another concern. In addition, the equipment needed to evaluate patients and administer the drug will be limited to large academic centers or large healthcare centers. And those who live in rural areas or very far away from these centers will be limited. Another question is, what about PET scans, and what is the coverage determination regarding PET scans? Previously, the Center for Medicare and Medicaid Services, CMS, has limited the reimbursement for the imaging procedure, this PET scan, which is capable of distinguishing Alzheimer's from other causes of dementia or memory loss, to once per lifetime of a member, one time. Or if that person was also enrolled in a clinical trial for Alzheimer's. However, in October, just a few weeks ago, CMS removed this provision and said that it allowed its network of Medicare administrative contractors, or MACs, to make their own PET scan reimbursement decisions. So those agencies who contract with Medicare will make their own decisions. There's much that is yet to be figured out. How often is it appropriate to get a PET scan? Is it once at the beginning to make sure that there is the right patient is selected, or is it every year? Is it every 6 months? Is it every 18 months? All of those questions have not yet been answered, and it will be determined by these Medicare administrative contractors. However, broader access to amyloid PET scans will enable earlier and more accurate diagnosis and better care management. Their use can lead to better health outcomes for people living with Alzheimer's or another dementia. The other question is, many people receiving the diagnosis of Alzheimer's, particularly mild Alzheimer's, could be under 65 and therefore not eligible to be enrolled in Medicare. Will private insurance cover Lecanemab? Usually, how CMS pays for drugs could affect how private insurance cover the drug. But that remains to be seen, because it is up to each private insurance carrier to decide whether or not it covers Lecanemab or PET scans or any other diagnostic treatment modalities. So that remains to be seen. And I will end here and hand it off to the next person.
Thank you, Dr. Emiru. Wonderful. Really, really appreciate it. Thank you to all of you who are submitting your questions in the Q&A tab. We have a bunch of good ones. So I really appreciate that. We'll now turn to Dr. Brangman. Dr. Brangman, thank you so much, and please take it away.
Okay, thank you for inviting me to participate in this discussion. And the conversation so far mirrors exactly the kinds of questions we're trying to figure out as we build the infrastructure to support patients on Lecanemab. Now, some of my concerns really will parallel yours. There are lots of questions and fewer answers right now, and we're going to learn this as we go. As mentioned, the study was only 18 months, and we do not even know how long therapy needs to happen in most people, and other myriad of questions. One of the most pressing issues is that we know that African Americans and Latinos in general have higher rates of getting Alzheimer's disease. African Americans about 1.5 times, 2 times, and Latinos about 1.5 times more than their white counterparts. Now, we know that race is not a biological determination. It is a social construct. And so we know that the genes that change our skin color or the shape of our eyes probably don't increase our risk of developing Alzheimer's disease or another dementia. And the things that do this are the social determinants of health, or in other words, how we experience and process years and years of discrimination or racism in our bodies. And so some of the premises of this amyloid theory were not even tested initially in large, diverse populations. So we really don't know what the full impact of amyloid might be in people of color. We also know that there are many other factors that go into developing Alzheimer's disease. And like Dr. Knopman mentioned at the beginning, we are dealing now with that definition of Alzheimer's that involves excessive amyloid accumulation in the brain. But we do know that years of hypertension, diabetes, stress, there was a recent article that even came out that exposure to air pollution, which may be disproportionately experienced by people of color, can increase your risk. So we do not know or have a full understanding yet about the amyloid hypothesis versus other hypotheses that may increase someone's risk for getting Alzheimer's disease or dementia. So the studies that we look at for Lecanemab did not include large numbers of Black people. So there were only 2.3% Black people who actually got the drug and about 2.7% who got placebo. And this compares to 76.3% of white people who got placebo, for example. We also see big groups of people like Black, Asian, and Hispanic, and we know that does not really give you any details of that person, because if you're Asian, for example, you could be from China, you could be from South South Asia, like from Indian descent, you can be Cambodian. These are meaningless categories that we as a society are stuck on, and they don't really give us the information we need about taking care of patients. So when the question comes up, how am I going to explain these drugs to my patients who might be African American? I will tell them that we don't have a lot of information, and they would probably be among the first groups that we will be collecting information about, because the numbers in the trials were so low. And the other thing is that as a geriatrician, I'm also looking at representation across the age span of participation in these clinical trials. And lecanemab, the average age was 71, which is relatively young in the geriatric world. And although they recruited people up until the age of 90, there wasn't a lot of representation in the old. So when I have a patient who's in their 90s, we're going to have to work and look at this very carefully as we make a decision moving forward. Now, the reason for this underrepresentation in clinical trials is a big one. It is not just in the Alzheimer's drugs, it's across all drug categories and all disease states. And this is primarily the result of the way academic medical centers develop relationships with different communities that they take care of. Because most clinical trials happen in academic medical centers, that's where pharmaceutical companies go to conduct their trials. And most of our academic medical centers have a two-tiered system for white patients versus Black and other people of color. So it's really time for academic medical centers to look at how they develop relationships and how they do community outreach and how they provide care to communities within their service area. And this is a big problem that we all have to address. Now, my other concern about these medications, lecanemab and maybe donanemab down the road, is that I think they're going to increase health disparities and inequities. And as Dr. Emiru mentioned earlier, these medications are going to have to be administered at academic medical centers because these are the places that have the healthcare workforce. They have the infusion centers, they have neuroradiologists, they tend to have geriatricians and neurologists. However, these numbers are still very low because our healthcare workforce really has a shortage of doctors across most specialties, especially primary care, where a lot of patients with early cognitive changes are first identified. So if you live in a rural area or if you live in a small town, you may not be able to manage all of the moving parts that are needed to get lecanemab. The other concern I have is that you have to have a certain amount of disposable income to pay for these copays. And one estimate I read is that it could be as much as $6,000 out of pocket to pay for all the copays that are associated with the PET scan, the ApoE testing, the multiple MRIs, the infusion chair copays. So $6,000 is a lot of money for most of my patients, and I'm not sure how many of them are actually going to be able to afford this. And especially since we recently did some initial inquiries and we found out that the ApoE testing alone could be $500 or $600. And it's not clear if that's going to be fully covered under Medicare. So we have a lot of work to do to build the infrastructure, first of all, to be able to administer this complex medication and monitor closely for side effects. We also have to work very carefully to select the appropriate patients, and we have to work with them to figure out all these other issues, such as can they afford the copays? Do they have the time to commit for an infusion that could last at least 2 hours twice a month? Some of my patients have service jobs that don't have sick time or personal time. So when they take time off, they actually lose money. I'm not sure they're going to be the ones who can afford it. So I think we're going to be looking at a very select group of wealthy people who have access to a big city and have the disposable income and the time to take this medication. And for somebody who has been working as a geriatrician for all these years, I've been advocating for all of these equity issues for so long. And my concern is we are now going to be reaching an area where there's a new therapy. And don't get me wrong, everybody is so interested in figuring out how to battle this disease or even eradicate it. This medication is not going to eradicate Alzheimer's disease, and it is going to require a complex infrastructure to administer it safely, and it's going to require patients who have the time and the disposable income to actually use this drug. And I will stop there and pass it on to, I guess, is it Dr. Borson next?
Yes, Dr. Borson. This is just wonderful. Thank you, Dr. Brangman. Thank you all the panelists. This has been great thus far. And Dr. Borson, please.
Yes, hi. So before I start with my slides, I'd like to Ashley to show us Dr. Knopman's slide showing the lecanemab placebo graph. There's a point I want to make from that picture.
Sure, give me just 1 second here.
Yeah.
Sorry.
And thank you, Dr. Brangman, for your incisive comments about this. I really agree with everything you've said, and you've said it so well. I've been really concerned about impact on existing inequities. And I'm also concerned about the expenditures for what's the bang for the buck that people are going to get. But I still want to see that first graphic slide.
Ashley, do you want me to get it? Do you want me to share my screen? Would that be easier?
If you have it handy,
I do.
Thank you.
Okay, so I want you to look. I want everybody to look at the numbers of patients down at the bottom who are on placebo and on lecanemab, and look at what happens over time. So 875 or 859 people started the drug at the beginning. 265 of the 875 finished 18 months. 299 of the 859 on lecanemab finished 18 months. Now, there are a lot of statistical ways of dealing with this kind of dropout. And in fact, those ways were used in drawing conclusions about the overall benefit of lecanemab. But if you really think about that and you ask yourself, well, which group would I be in then? Would I be in the dropout group? And why would I not have finished 18 months? If we're accounting for outcomes at 18 months, we're seeing that a minority of enrollees finished the 18-month trial. That means the majority did not. And although statistics are very useful and widely, wonderful methodologies do exist to adjust for dropouts, there are a lot of people in there who might be biologically experiencing something quite different from those who finished. And I would like just people to note that there's a caution here. And now we can go to my slides. Thank you very much for that segue.
Sure.
Okay, so I want to focus really on the personal side of this. What are the things that you should be thinking about if you are a person who might consider using lecanemab yourself, or donanemab for that matter, when it is approved, or you're somebody who cares about somebody who may be a candidate? So this is really more about what should we be thinking about together. Next, please. So first, let's talk about what's the real meaning of mild cognitive impairment and mild AD dementia. So Dr. Knopman has talked about what's required to establish these diagnoses, but what does it mean to you and me? So these are the stages of Alzheimer's disease that qualify for the new treatments. So geriatricians typically like a scale called the FAST. It's a functional scale. They like it because it's easy for people to understand. And so I've used the FAST staging here because it speaks about stage in plain language. So mild cognitive impairment, or stage 3 on the FAST scale, means this. There are subtle changes in memory and function, but maybe it's only the family and close friends who notice it. They're repeating questions, repeating stories, inefficiency with tasks. That could affect work performance and really complicated activities, slowing down, having to redo, just taking longer to get things done that used to be quick. Staying on task takes more effort. I want to emphasize the effortfulness aspect of MCI, that you can still do an awful lot of stuff, but it takes more effort. You get more tired. And then very complex tasks like organizing a party or doing your taxes may be too difficult, and you may need to turn those over, or at least get help from somebody else. So mild AD dementia is similar to stage 4 on the FAST scale. Signs of cognitive impairment are pretty apparent, and they cause some everyday disability that requires that you get help from somebody else. Forgetting recent or important past or future events, dates and times. Stuff that is second nature, like what your address is at home, what your phone number is, names of your relatives, how to do simple things that you've been doing forever, even how to drive usually can still be used in mild dementia stage. But you need help or oversight to manage everyday cognitive activities, such as paying bills, organizing transportation, following a new recipe, planning what to wear for the weather. Next, please. So what are the questions to ponder? And this is kind of, let's take a step back. What's really important to me in my life? What's important to me now? And what is it that I might benefit from, how might I benefit if I were to use one of these? So some people have described the effects of lecanemab as offering an average delay in progression of about 6 months. And so what does this mean to me as an individual? Notice the number of people who dropped out of the trials over, consistent dropouts from one assessment to the next. What would I expect of the treatment? It's important to realize that that many people with mild cognitive impairment and mild dementia don't notice any progression over a 6-month period. No progression. Some actually find that they're doing better. The more they practice, they may do better. There's still learning that occurs during these stages. Then how will receiving this treatment affect me on a day-to-day basis? Is it going to interfere with my plans? Was I going to be taking a trip somewhere? Did I want to go see the grandkids? I was going to be gone for a month. Well, how do I get my treatment if I'm not around? How about what really matters to what I do on a day-to-day basis and what I value in my life? And then finally, who needs to be involved in my decision? So in a kind of offsides conversation with Dr. Knopman, he mentioned, I don't want to be the only person who's deciding about a drug for my patient. I want that patient has to be really involved. And I would say it's not just the patient who needs to be involved, it's people who care about that person, the close people, and for a couple of reasons. One is they care. Number two, there are deaths with these drugs. These deaths have been associated with ARIA, these clear side effects that are specific to these treatments. So death is a possibility as a result of this treatment. Although it is rare, it does occur. So that means that the people who care about you need to be very much a part of the decision. Next slide, please. What about what should you be asking your doctor? Will I be cured of Alzheimer's if I receive treatment? The answer is no. This is not a cure. It's kind of like, think of it like heart failure. These conditions in the brain, Alzheimer's disease in the brain is a form of brain failure. We're used to thinking about the heart as a it's a vital organ. The brain's a vital organ. Heart failure is also not a curable condition. Heart failure, like dementia, is a progressive condition. And although we have extremely useful therapies now that can prolong life in heart failure, we're not curing heart failure. So chronic conditions are by definition not curable, and most of them are progressive. So no, I will not be cured of Alzheimer's if I receive treatment. Progression will continue. What's involved in the treatment? Dr. Knopman talked about this. What will I need to do and when? Dr. Brangman talked about this. What are my family's responsibilities? How much will it cost me? Next. What's it like to get the treatment? What have other people experienced? Well, this is one of the things that I wanted to point out to our listeners today, and that is that we don't really know what people experience. I've heard that people don't complain much about problems. They tolerate these agents pretty well if they don't have major ARIA-related effects. But what people experience is not part of the outcome measurement that clinical trials use. So there isn't a lot of inquiry into what's it like to get the treatment. That means that doctors can't tell you very much unless they've been involved in the clinical trials themselves. And then they can tell you, well, of the 10 patients that I had who were in the trial, nobody complained of anything. That's what you can hear. But I think we need to be considering how we involve potential trial participants in the actual design of our trials and what we measure in those trials. Next, please. What side effects should I expect and how serious could they be? I think this has been pretty well covered. They mostly surround ARIA, those amyloid-related imaging abnormalities that sometimes cause clinical effects and have caused a few deaths. Next, please. Should I wear a medical alert bracelet showing that I am on this treatment? This is something that I haven't seen in print, but I would like to propose to everybody who is considering it. A medical alert, why would you want a medical alert bracelet showing that I'm on Lecanemab or donanemab? The reason is that ARIA can present looking a little bit like a stroke. And if you turn up in the emergency room looking as though you've had a stroke, like as not, you're going to be put on a major anticoagulant to try to forestall progression of your stroke and reverse its effects. And that can be disastrous, and it has been disastrous for people on anti-amyloid antibody therapies. So a medical alert bracelet, I would say, yes, you should wear a medical alert bracelet saying you are on the drug and naming what that drug is. Next, please. How long will treatment last? Well, that's the question. I think Dr. Knopman has mentioned that. Dr. Brangman mentioned that also. And I think this is something that there's no answer to right now. We know how long the trials went on. We don't know how long treatment should last. Next. How will it affect my overall health and other conditions that I have? I won't dwell on this because Dr. Knopman has covered this pretty well. Mostly this is about conditions that are excluded, that if you have them, you cannot receive this treatment. Next, please. And what risk might I face and what can I do to reduce my risk? Those questions have already been addressed to some degree. More to talk about, but not right now. Next, please. Do I have any conditions that might indicate I shouldn't be treated or that I would not do well? Yes, if I have a ApoE4 homozygosity, I probably shouldn't be treated, and I may not do well. And I cannot be treated if I'm on an anticoagulant, at least not right now. Next, please. So ask yourself, how do I want to live? Now we're really talking about if there's been a diagnosis of Alzheimer's disease pathology causing cognitive impairment. These are questions that everybody could benefit from asking. How do I want to live right now? These diagnoses tend to be life-changing for people. It's getting a diagnosis when you've known that something was wrong, but you hoped it wasn't serious, and then you get a diagnosis of a progressive brain disorder. it's a challenge for everybody to come to grips with, and it can cause a crisis in people's thinking about themselves and their lives. So how do I want to live now? And let's just run through these bullets, Ashley, and what else might help me? What information and support do I need? Let's think about all the different things that can help me live well with the condition that I have now, quite separate from whether or not I have treatment with an antibody therapy. Do I need to pay more attention to my mental well-being? And who's on my team? There's you, family, friends, your counselors, your spiritual advisors and other counselors, healthcare practitioners, community centers. You can create around you a pretty big team that will help you to cope with the condition you're dealing with. Do I need to make changes in the routine of my life? How do I set up a plan for my well-being, health, and future needs? And these are the questions that everyone with a life-changing diagnosis needs to ask themselves in order to plan ahead. And then finally, for some people, there will be a motivation to help make life better for others who are experiencing what I am. And that has nothing necessarily to do with the topic of the day, Lecanemab or donanemab. It has to do with, if I know what this is like now, then I know something that many people don't know. And can I share this with others for their benefit? Next, please. So what are the goals that are worth working for if you have a diagnosis of a progressive brain disease? I like to say that a goal worth working for is crisis avoidance. No crisis. Know your risks, plan ahead, work to maintain mental and physical health, seek information that works for you from whoever might have some information, and it might come from surprising corners. Invite others in, create more joy, do what you love, make it a priority, and try something new. So these are bits of advice for people facing potentially serious progressive conditions. And I'd like to end on this note of having Alzheimer's disease is a condition that most people who have it don't die of. Oddly enough, we like to think of, we've heard said it's a terminal disease. Well, yes, that's true, but most people don't die of Alzheimer's disease. They die of something else. So keep that in mind too. And that's it.
Well, thank you all to the panelists. Just spectacular information here. We have been getting many, many questions, and many of them are really good ones. We unfortunately will not have the time to get to all of them. But what I've been trying to do behind the scenes here is compile some of those that I thought were most compelling and get at some of the many, many essential points that all four of our panelists raised today. You know, I apologize for not clarifying this sooner, but I think before we get into the Q&A itself, quick question for each of the panelists, and this was brought up by one of our attendees. Do any of the speakers have relationships with either of the manufacturers of Lecanemab, such as Eisai and Biogen? Can you please let us know? So I'll start with you, Dr. Borson. Do you have one?
I am on an advisory group for them. My major role on the advisory group is to, on the groups I sit on, is to speak on behalf of the general physician, the primary care physician, and health systems that are dealing with people who have dementia. So I've never been involved in a clinical trial, and I do not promote the drugs. I speak as about delivery of medical care to patients.
Yeah. Thank you, Sue. And to clarify from my standpoint, I have no relationship with Eisai or Biogen. Dr. Brangman?
So I am on the advisory board for Eisai as well as Genentech Roche. And I speak as a geriatrician and also as somebody who has to give voice to the needs of the underrepresented groups in this trial and try to make sure that the trials are inclusive or meet their needs.
Wonderful. And Dr. Knopman?
Yes, I don't take any money from any of the manufacturers. I sat in on one consultation with Lecanemab, but I didn't get paid for it. I don't have any, I'm sorry, Lecanemab. I don't have any relationship with Lilly. I was a site investigator for Aducanumab, but I didn't receive any personal compensation.
Wonderful. And Dr. Emiru.
I have no relationship with either one of the pharmaceuticals or any other organization associated with what we're talking about today.
No, thank you. That was a very good point that was brought up by one of our attendees. I think you would all agree. This has by no means been a cheerleading session. Let me just say that. I'm saying that from my own opinion. So, I mean, I think what the information you're getting here is balanced and from the perspectives of both providers and then perhaps most importantly of all people living with dementia and their families as well. Let's get right into the questions here. And I have informally direct them to one of the panelists, but any of the panelists can weigh in as they see fit. So this comes from Carlos Olivas. As for people like myself, a primary caregiver who have a family history with Alzheimer's, why it is important for persons of color to enroll in clinical trials? Dr. Brangman, I thought maybe given what you talked about, you may want to start answering this one.
So as I mentioned, it's not for a biological or a genetic reason, but there are other issues that could impact the ability for a person of color to complete a trial or may have particular issues with a drug. I think we need full representation of all these drugs so then we can make better decisions about which drug is appropriate for whom. And for many years, either we've been excluded from these trials or we've been included in trials that were not really to our benefit and were actually harmful. And we are past that era where people were exploited and used inappropriately to advance healthcare, probably for other people and not for people who are Black or brown. And now there are checks and balances in the systems to make sure this doesn't happen. And it is a matter of feeling that trust and that security that participation in that trial could help you or also could help your friends and family and other people. So I think representation in these trials is very, very important. And it's not just for the Alzheimer's drugs. This is for any disease state. So whether it's a cancer drug or a blood pressure drug or a diabetes drug, I think we need to have full representation across the age span and across racial groups.
Wonderful. Thank you so much. I'm going to direct this next question to Dr. Borson. This comes from Peter Whitehouse, actually. Would someone address the opportunity costs associated with paying for these drugs? Public health, improving care?
It is something I can't really talk about that in a way that goes beyond attitude. And my attitude is I'm very concerned about the expenditure, planned expenditures for drugs like this when we have so many unmet medical and psychosocial needs for our patients. So, and I understand that we have different funding streams for medical care and for psychosocial care, and ne'er the twain shall meet, although there are efforts to integrate these much, much better. I really think I'm dismayed by the anticipated expenditure for treatments that have effects of this small magnitude on a small percentage of patients who need our help.
Joe, I'd like to make a comment. Oh, go ahead, whoever was.
So I just wanted to add that CMS actually increased Medicare premiums across the board, partially to cover the cost of these drugs, where there's only a very small percentage of Medicare recipients that are actually going to benefit from this. And when I talk to my patients on a regular basis, they want more help to stay at home. And they're always shocked when they find out Medicare does not cover that kind of care. Medicare will pay for you to be in the ICU, but it won't pay for you to get the kind of care at home. So I spend a good deal of time helping families who are shocked and dismayed when they realize that the services that they actually want are not covered at all by Medicare.
So I
Right.
think we need to distinguish as we're physicians here that when we're sitting in front of a patient, we are not representing the public health community. We are representing our patients. And if our patients should desire this therapy, I don't think that it's appropriate to tell them that they're wasting, that it's not a good use of resources. In front of my patient, I want to tell them the whole story. And as you've heard, I have a very nuanced view of it. But if it's something that they wish through shared decision making, that they should have an opportunity for to receive, and it shouldn't be a matter of a public health type to tell me they can't afford it. So I think we need to be careful what hats we're wearing.
Mhm.
So I agree with that. And as a center of excellence, my job is to offer FDA approved drugs to people who are interested. The key point is making sure that they make a good decision, that the right patients are selected, and they can make an informed decision about what it means to be on a monoclonal antibody. It is not my job to tell somebody not to take something. I mean, my
Right.
whole career, patients may do something that I wouldn't personally choose, but that's not my role.
Sharon, you and I are on the same page on this.
Well, I can't disagree. I don't want to be excluded from this conversation. I think that Joe asked me to comment first because I am a co-lead of a public health center of excellence. But the issues of policy are really different. They're very different, and we could, and Dr. Whitehouse knows very well what those issues of policy are and how policy and clinical need and clinical ethics and professionalism don't align with each other at all points on the trajectory of any disease. So yes, our job as physicians is to help our patient and to work with them around what they want, what might benefit them, and to give them the best information we have. But it isn't about policy. Clinical medicine is not about, with patients, is not about taking a policy position. And I think we're all well aligned on that score.
Yes.
Thank you. Great conversation here. Dr. Emiru, I'm going to direct this next one to you. We get a lot of questions about cost, as you can imagine. And so we'll start with this one, and I'm sure there are others we can turn to if time permits. So what are the coverage options for those insured by Medicaid or those who are uninsured or underinsured?
Yeah, so for those who are insured by Medicare, the Center for Medicare and Medicaid Services, CMS, has said that they will pay for that. So as long as a patient has Medicare, and particularly Medicare Part B, which covers outpatient visits and this medication, that will be covered. So that's one. However, it does come with a co-insurance as well as a deductible, and so that will have to be met. For those who are covered by Medicare but under private Medicare Advantage plans, then it also depends on, it will be covered, but it depends on, the co-pays and the co-insurance and the deductibles will depend on that type of what type of Medicare Advantage plan the patients have. For those who are uninsured, this will be uncovered, and it is a very costly medication to have to pay for it out of pocket. Those who have private insurance, who are particularly those under 65 and therefore not eligible for Medicare, my guess is that over time we will see more and more private insurance covering it, but maybe with a strict limitations around who gets it, specific patient selection criteria and prior authorization. But again, that depends on each private insurer. My concern is that even for those who are covered under Medicare, there are significant out-of-pocket costs that may be cost prohibitive for them to get this medication.
Thank you. And I'm going to stick with you really quickly, Dr. Emiru, because a variance of this question came up multiple times as well, which is what are the costs associated with the infusion procedures required as well as the MRIs? These costs, from the questioner's understanding, are on top of the cost of the treatment itself. Will Medicare pay for those?
Absolutely. So Medicare will pay for the associated infusion costs, and again, or the imaging, particularly PET scans. Again, how often is not determined, or an MRI. The question is, the co-insurance and the deductibles and out-of-pocket costs will still incur on top of the medication out-of-pocket cost. So, the supplies, the clinic fees, and, the MRI fees, if we're doing it quarterly, each time there is an MRI, the out-of-pocket costs will continue to accumulate. And that is a concern. That is a huge concern.
And really quickly, Dr. Emiru or others on the panel, the question about Medicaid and Medicaid coverage. Persons on Medicaid, will they be covered?
So Medicaid coverage is largely determined by each state. In Minnesota, I can speak to Minnesota, the preferred drug list for Minnesota Medicaid currently does not include lecanemab. For Alzheimer's, the only medications that are currently on the preferred drug list are donazepam and memantine. So that is as it stands right now. What does the future hold? I don't know. I don't know if Medicaid will cover it, and each state, like I said, is different.
Wonderful, thank you. I'm going to direct this next question to you, David. I think it gets at a really critical point in this. Can you describe what you mean by meaningful change? Now that the drug is approved, do you see similar slowing in people who have started the drug in clinical practice?
Well, that's a great question, and I think it's important to think about what the benefits of the drug are. I think, as I said, and Sue certainly emphasized, Dr. Borson, the drug, or maybe we all said it, the drug does not bring about improvement. It delays worsening. And it is the case that is virtually invisible to people. And, we have a long experience in observing that kind of thing with the drugs like donepezil and memantine that have been approved for Alzheimer's disease dementia for a long time. You can't tell whether the medication works because you don't have an external comparison for delaying worsening. But the graph that I showed had to do with a research scale that basically translated for most of the people shown on that graph in going from mild cognitive impairment to mild dementia. And whether lesser degrees would be important is really unknown at this point. That I can tell you that in the field, there's a raging debate about what clinical meaningfulness is. And ultimately, I think it comes down to the beliefs of individual patients and their families. I couldn't emphasize that more, together with the physician, about what the goals would be in terms of delaying worsening. But we're in a period of time when the amount of information is really quite limited. Just 2 weeks ago, some data was shown at an international meeting that showed apparently that with lecanemab, that going out to 30 months, that gap between the drug-treated continuously drug treated and those who were on placebo who then eventually received the drug stayed about the same. It didn't expand, neither did it disappear, fortunately. But the question is whether that delay of percentage points, or sometimes how it's discussed as about a 5-month delay, if that's the same at 30 months as it is at 18 months, hard to know how much benefit that is.
Wonderful, thank you. Robert Freeman makes a really interesting point in the Q&A tab. He mentions, again, getting back to Medicaid. Medicaid is required by federal law to cover all FDA-approved drugs. However, they can prior authorize it and put up other limitations. So I just thought that was an interesting comment. And I'll turn to a question that Robert Freeman raised, and I'll direct this to Dr. Brangman and David potentially too, as well as others. Are Black and Latino individuals also are at greater risk for ARIA?
We don't know. Yeah,
We don't know.
Yeah. That is getting too granular for us to even make a statement, given how few people were in the clinical trial.
Right.
But I would say you're just as much at risk as anyone else, because this is not a racially based drug. This just is a patient factor issue. No matter
That's right. That's right. And unfortunately, as Dr. Brangman said, the number of African Americans who were in the Lecanemab trial or in the Donameb trial was very, very small. And so we just don't have any experience with it. But my view is that it's unlikely, because I don't think the biology is any different.
Yeah.
So one thing, though, if I might comment, is that there's been talk about the relationship between brain amyloid and cognitive performance, and what influences cognitive performance is influenced by education, by lifetime employment, by neighborhood factors, by, I mean, many different aspects of an individual's experience influence their performance on cognitive tests. And if a person comes from a background in which intellectual achievement was not a high priority, or was not possible due to limitations in environment, then it's the relationship between cognitive performance and amyloid in the brain may vary from person to person. And so there has been conversation about both the unfairness of underrepresentation of people of color in clinical trials, but there are also some legitimate questions about how we think about the relationship between brain pathology and cognition that we have yet to, we all need to be mindful of.
Great, thank you so much. So the next question, this comes actually from Dr. Ken Hepburn. Again, I think it's a really critical one, and I'll really direct this to the whole panel here, but what do the essentially meager results of the Lecanemab trial mean for the amyloid hypothesis? My understanding is that if there was a reduction or elimination of amyloid from the brain, that the disease should not progress. However, it still does. So is this still an important basis for inquiry?
I wonder if I could perhaps start with that. I have to say hello to my friend Ken.
Yes.
I believe that this whole idea of a simplified amyloid hypothesis is really, it's not a basis for conversation. Is it the case, however, that brain amyloidosis is a critical part of the biology of Alzheimer's disease? Yes. Is amyloid by PET scan and CSF studies important for identifying people at risk? Yes. And getting to the therapeutic issue, does amyloid lowering produce clinical benefits? And by golly, the answer is yes. And so I'm not going to talk about an amyloid hypothesis, but I'm going to talk about the following statement, or say the following statement. The studies with lecanemab and donanemab, however modest, show that some degree of amyloid lowering is beneficial. Now, I happen to believe that and this has been alluded to, actually, Dr. Borson just mentioned this, there are many other determinants of cognitive decline, other biologic determinants and other social determinants. And so it's utterly naive to think that amyloid lowering is going to have the kind of dramatic effects like taking vitamin C to prevent scurvy. But the fact is that some amyloid lowering does improve, or does bring about clinical benefit, however modest.
So I think that Alzheimer's disease is much more complex than finding one thing that's going to be the cause or the fix of all. And we know
Sure.
that there are many more factors that come into play. So yes, there is some role for amyloid, but it's probably not as big as everybody has been waiting for. Everybody is waiting for the one thing. And I think that is a misrepresentation of how we're going to solve this complex mystery here.
I couldn't agree more. This is something I've thought about for decades, like most of us, that amyloid is a very interesting, the dynamics of amyloid in brain development, in fetal life, in early postnatal life. There's some very interesting findings about amyloid and its role in brain development. And so there is a hypothesis that amyloid, is as unpopular as it is right now, that amyloid is in some ways a secondary reaction of damaged neurons to try to improve their function. And so, or restore a kind of developmental pattern. It remains a very unpopular idea, but I think there's a lot of room for much more understanding of what are the primary pathologies in addition to those that we use to identify a disease state, namely Alzheimer's disease identified by amyloid and tau. There's a lot more basic biology that is being reflected in clinical trials now and in basic science in laboratories. So I think we just have to keep an open mind.
So my concern is that we've done so little in any other areas. We have just focused on amyloid.
Yeah.
And there's still a lot of other amyloid-based drugs in the pipeline waiting to come out. So my concern is that everybody's been jumping on this one bandwagon and we may be missing other realistic hypotheses out there. Because after a while, it gets hard to get funded for something if you sound like that reckless wild person with a crazy idea. Everybody gets funded if they jump on the same bandwagon. So I think we have to look at people who solve complex problems as that crazy person in the corner may have a good idea.
Well, we want to make sure they have a good idea. If I could just say, at this international conference 2 weeks ago, although it was dripping with amyloid indeed, there were many novel ideas that were put forward in various phase 2 trials. So, and there is active investigation in tau therapeutics now. So it's not so dire, but look, the amyloid was a low-hanging fruit, and that's human nature to go after low-hanging fruit. We've got to go up the tree now, and I do think that's happening. It's difficult.
So could I just add one perspective to this that was also introduced at the CTAD meetings, the clinical trials meeting, and that is there was publication in one of the Alzheimer journals of what might geroscience, the science of aging, bring to the discussion of therapeutics for Alzheimer's disease. And I think that's been a missing perspective. Dr. Knopman pointed out that the average age of people in trials was about 72. That's about the average age of people in Alzheimer's Disease Research Center cohorts. And yet the great majority of people with dementia are much, much older than 72. And so the social science literature, especially from medical anthropologists, has really been focusing on and Dr. Whitehouse's own perspective on aging and trying to broaden the dialogue about aging processes as crucially important in the evolution of dementing diseases, not just one molecule we call amyloid, or even two, amyloid and tau.
And we can't forget that our bodies accumulate disease over a lifespan. So aging well starts with good prenatal care.
Yes, it does.
You can't just
talk about an unpopular idea.
Right, I know, but we can't just pick out age 65, which was politically and randomly selected as being old for reasons that had nothing to do with science. But we can't just say 65 is when you're old and now we should look at X, Y, and Z.
Right.
So this is another really interesting question. I think it dovetails a lot with our focus on emerging therapies, which is this. This is from George and Mary Ellen Buckby. There have been some media reports about new blood tests for early detection of Alzheimer's disease long before any symptoms become apparent. What is the situation with these tests? While not currently approved, what is the thinking around early detection followed by application of lecanemab, donamab for prevention of disease in high-risk populations? So I'd love to hear the thoughts of the panel on this one.
Well, maybe I can start off just by saying that at this point, their patients who are asymptomatic, even if they have alleged biomarker evidence of elevated brain amyloid, should not be treated, period, should not be treated. There are 2 clinical trials that are underway, one with lecanemab and one with donanemab, that are addressing this problem as we speak. It will take several years before those results are known, but in the meantime, that would simply be a no. Evidently, there is a blood test that's commercially available from I can't remember the lab company that
Quest
offers
Diagnostics. Quest
Quest,
Diagnostics.
yeah, no, thank you, right, which we would strongly discourage. It, I mean, it makes business for me, for people coming with a positive test and they didn't know why where it came from, but it's, in all seriousness, there is no value in asymptomatic people obtaining this information, and in symptomatic people, they should see a physician and have tests that have substantially higher diagnostic accuracy, either with CSF or PET, and a careful clinical history and exam.
So I would agree with that because we don't know what these positive tests even mean, and it's just going to increase the level of anxiety and worry. And it could have implications for life insurance or a job or something. You might be considered to have a pre-existing condition now, even though we don't even know what that means. So I think there's a commercial or a financial value that is way ahead of our clinical value. I would not recommend people just take these. You know, 23andMe created a lot of family distress across the
Yes,
land.
right.
And
It's a great Christmas present, isn't it?
Yes, yeah, it disrupted all sorts of families who didn't know what mom and dad really did. But I think that this test has that level of possibility to cause that much stress without a lot of answers.
Yeah, I couldn't agree more. I mean, this particular test is geared towards primarily people who are 50 and older who suspect that their memory and thinking might be impaired for whatever kind of reasons. And it's not necessarily that the possibility of a false positive is really high. This causes an undue anxiety and burden on patients and families. In addition to that, there are a number of different reasons for why someone may have cognitive symptoms that has nothing to do with Alzheimer's disease. You know, and so as a neurologist, I mean, small strokes, sleep apnea, thyroid problems, vitamin B deficiency, other medication interactions. I mean, there is a whole slew of things for why someone's memory or cognition may be impaired temporarily or on a permanent basis. And these types of tests really increase that level of anxiety without having a clinician address the questions that patients and families may have in front of them. And I'm also seriously concerned about because these medications lack the protection that genetic testing has for future life insurance or employment consequences. This may result in something that is unexpected. So couldn't agree with you more.
So I have a comment here from Matthew Janicki. Dr. Brangman makes excellent points about the uselessness of political categories of our population. clinical trials need to include subgroups based on biological rationale, not demographic parsings. And that actually leads to another comment, which again, I think is critical, which is it's very important to have representation from underrepresented racial ethnic groups, but I haven't heard any discussion regarding LGBTQ plus populations who also face discrimination and have an increased risk for Alzheimer's disease. I don't know if anyone wanted to comment or discuss that. One thing I will note is I'm fairly certain in the trials, LGBTQ was not measured or included that I could tell. I mean, but yes, please.
I'm not sure that's a relevant question on the eligibility check sheets, but
Yep.
that is an important point to bring up. And I think that our clinical trials should reflect the members of our society,
Yep.
because that's who's going to be taking the drugs. So again, I don't think there's a biological reason for LGBTQ to expect a different outcome, but there are social aspects to medical care that impact our health, and we need to make sure that our studies are inclusive of all the people that we take care of.
Okay, thank
I
you.
think we'd all agree with that. Nobody could disagree.
Couple of final comments, and I'll have one last question here as we're coming to the end of time. As you could tell, the many, many great questions. We could go on much more, but we have to end here at the half-hour point. Meg Boyce mentioned this as a comment. The Quest test is not FDA approved, and it's giving false positives. And I believe, and that's the case, correct, panel?
Well, yeah, it's guaranteed to give lots of false positives. The blood tests were intended to be used only as a screening test for the next stage, and therefore of diagnostic testing like a PET scan or a lumbar puncture, and wasn't intended to be used in the primary care office for somebody who left their keys in their car.
So there was an outstanding presentation by one of the leaders in biomarker science, who's been doing very high quality research on biomarker sensitivity and specificity at the recent Alzheimer meetings. And her view that she supported with significant amounts of data is that these tests are not ready for wide application. They are research tools, and there are many, many gaps in the application of blood-based biomarkers that have to be filled before any story can be told about who in general medical care might benefit from having biomarker testing, separate from enrollment in a therapeutic trial or a clinical treatment pathway.
And I'll add one more thing to that. These tests are not cheap and are not yet covered by any insurance. And
How much is the Quest?
The Quest one used to be $399. I think recently it was reduced to $299. Either way, this is a hefty price for something that has relatively little value right now.
Wonderful. Let's conclude with a final question that actually is near and dear to my heart. We won't have much time to address it, but as clinicians and scientists, we are all thrilled that the National Institute on Aging, as well as other federal funding agencies, have increased support for Alzheimer's disease research. Do you think the funding assignment is proportionate to the needs of persons and families living with ADRD? Is the promise of a cure interfering with advancing the science and care of persons with ADRD? This comes from Raphael Samper-Ternent. Any final thoughts or comments on this? I mean, I can add a little. I'll just give my thought really quickly as someone who does work in dementia care. Prior to the National Alzheimer's Project Act and this increase in funding, I would have very much agreed with this. Much of the research and funding was not spent on evaluating approaches to care for people living with dementia or their efficacy or effectiveness. At least it was disproportionately funded. There have been major advancements, however, in the funding to support this work. I've been a beneficiary of that. I think others have as well. And one hopes that that continues, because I do think there are definite advancements occurring when one thinks of how to enhance and improve optimal care for people living with dementia. For example, collaborative care models, various approaches in communities, et cetera. But any other final thoughts on part of the panel?
We're appreciative of Congress for being supportive of Alzheimer research Alzheimer and related disorder and dementia care research, covering the whole gamut of this very complex disease.
All right. Well, why don't we conclude here? We're right at 11:30. I want to really thank our wonderful panelists here today, Dr. Borson, Dr. Brangman, Dr. Emiru, Dr. Knopman, for a really thrilling discussion about new and emerging therapies. And I'm glad that we were able to answer many of the questions posed today. I know we couldn't get to all of them, but again, just wonderful information. All of this information will be shared with you. And also, really quickly as reminders, we also will be putting this information on these web pages here. So they'll be available at any time to access. We've been sharing our frequently asked questions sheet with you. And as a final reminder, if you have a chance, please do complete the evaluation from today's webinar. Thank you all. Really appreciate it. If there's anything we can ever do, please feel free to reach out to us. You see my contact information here. I also really want to thank Ashley Millenbaugh for her excellent coordination support for this event as well. Thanks, everyone. Have a great rest of your day and really appreciate your time. Thank you.
Thank you.
Bye-bye.